All, this is Dr. Mubin Sayed from Drbeen.com. Welcome to one more show. Today we are going to talk about some of the news that are really important and interesting as well. So we'll start with our favorite CDC. So CDC has today changed their site or the page once more that talks about the spread. And in their new page, the spread of the COVID-19, in their updated page, they are saying that the airborne spread or the spread via aerosol is not possible, or we do not have evidence for that. And there is a standard disclaimer that I see on their page that for everything they just simply say that the literature is evolving and the information is evolving and we are gathering more information. So we are really not clear at this time for what is happening. And so that gives them this flexibility of changing whenever they want and to whatever they want. So I thought that that was interesting and kind of a little incompetent as well. So let's look at that first, and then we'll continue. And welcome, everyone. So check this out. First of all, here is an article. I have the link to this article. In this article, what they're talking about is what is exactly an aerosol versus a droplet, and what is airborne particle. So let me just look at these here. So look, what happens is, so let's say these are the particles that come out of our mouth as we are talking or sneezing or coughing or like that. Now, when the particles come out, these particles can have various sizes. And we've talked about this multiple times before as well. So they can have various sizes. For example, here, there is a particle that is larger than 5 micrometer size. And the researchers have different definitions of what is exactly a droplet. Some of the researchers say that a droplet is a particle that is size greater than 2 micrometer or 5 micrometer or 10 micrometer or 20 or even 100. So there is a disagreement or different definitions of what is a droplet. However, one concept that is important to keep in mind with the droplet is that a droplet is something that when it comes out of our mouth, it is big enough, it is heavy enough that it would start to fall towards the ground very fast, and it would fall within 6 feet to 10 feet and so on. The fall will also depend upon the velocity with which it is coughed out or sneezed out or breathed out. So that is a droplet. Droplets will fall to the ground. On the other hand, if the moisture amount and the temperature and the environment is correct or suitable, then it is possible that the droplet would travel in the air, and while it is traveling, if you see here, it would lose some of its substance or some of its moisture and become lighter and lighter. And when it becomes lighter, it may reach a point where it has become so small and so light that it will not fall to the ground that fast. It would just stay suspended in the air. When it becomes suspended in the air, we call this an airborne particle, or we call that aerosol, or we call that a droplet nucleus, a small particle. And again, the definition of the size of how small are different. The basic contention here, why CDC continues to change their position, there must be a scientific reason. And I wish, if you look at this CDC site, I wish that we can ask them that when they provide a guidance, they kind of put some sort of a reference on the guidance so we can actually see where they're coming from. And then when they change it, we can understand why did they change to something else. At this time, it's all subjective. Somebody sitting in CDC just keeps pressing some buttons, and one button presses and they go this way, and then the other button is pressed and they go that way. So here, what they're saying is they had taken a stance that the transmission of COVID-19 is possible by droplets and by aerosol or airborne particles. However, before that, they had a stance that the transmission is only possible with the droplets and not with the aerosols. So now what happened was their stance was droplets only, then it became droplet and or aerosol as well. And today they changed it back to droplet. And here is the funny thing about this. The funny thing is, it is not political anymore the way they are doing their stancing. So some people have put the comment that this is because they want to be, the head of CDC is appointed by Trump, and they are trying to support Trump, and Trump wants the businesses and schools and things to open. And so they want to make sure that the closed spaces are declared okay to work in. And because of that, the aerosol is the danger that they have said, CDC, that in the closed spaces, the aerosol stays suspended. And when we inhale that, we can get COVID-19. So now they're trying to say that aerosol is not a problem. The problem is, they used to say it is droplet only a few weeks ago. Then they said it is droplet plus aerosol. So whatever is the position of one party versus the other, they went from one position to another. And now they have changed the position once more. So they're really not on any one side at this time. I think they're not even their own side at this time. But that is what was the crazy part today, that they have declared that this is what is going to happen. So here I try to make a tiny cartoon where CDC and us are all now confused for exactly what is the right thing. Is it this tiny particle, the aerosol, can it do it or not? Can it transmit or not? And here is the droplet, and can that transmit or not? The scientific data shows that both of them can carry COVID-19 and both of them can transmit. The aerosol would stay suspended in the closed environments for longer period of times, for hours, and somebody who is infected, when they are sitting in a closed room, they leave the droplets there or the aerosol there. When they go away and the room is, even if it is empty, and if you walk in and if the suspended aerosol is there, you can get infected. That is a scientifically proven information. So I wanted us to kind of be aware of where the CDC stands. And it would be interesting, because we talked about this a few weeks ago as well, and some of the cool beans had pointed out that you can use Web Archive to see their previous edits. So check this out. This page here from CDC is today's page. Today is 21st September. So here they're saying these droplets can land in the mouths or nose of people. So droplets, right? So through respiratory droplets produced when an infected person coughs or sneezes or talks. Now check this out. This is Time Machine, and I brought in their page from September 1st. I do not know when did they publish what, so I'm just looking at various pages at random. So this is September 1st, 2020. And here they are saying, through respiratory droplets produced when an infected person coughs, sneezes, or talks. So this is exactly what they are saying today, correct? But between these two dates, 1st September and now, somewhere between them, they had one more update. And that was, look at this one. It is possible that COVID-19 may spread through the droplets and airborne particles that are formed when a person who has COVID-19 coughs, sneezes, sings, talks, or breathes. So somewhere, I don't know exactly what date they published this. So today they came out and they said, sorry, we made a mistake. It was an erroneous publication. We are removing it and we would fix it. I cannot seriously believe that an organization like CDC, on this specific page, we have talked about now droplets and aerosols like 6 times. On this specific page, they just do not, they're so lost. They're disoriented at this time. I cannot imagine, why do we follow such organizations that between a few days cannot take a stance? They need to look at the science to understand it and maybe correct us as well. If we are looking at the wrong science, they should put the references out here. They should say, according to this reference, according to this science, you guys should think this way. To me, it looks like they're trying to please everyone, and so they'll have all kind of stances available on their website. One day they would say one thing, and the other day they'll say something else. So anyways, that is enough of a venting, but I thought it was interesting for us to see what they're doing. Really, they're doing this. How big is CDC? All right, moving on. Otherwise, I'll spend my whole hour here. Second piece here, Oxford's or AstraZeneca's vaccine. So we talked about this vaccine a few days ago as well, that there was transverse myelitis that developed in one of the women in UK who was participant in the phase 3 trial of this vaccine. So the trials have resumed, and the trials resumed because the independent committee that was supposed to look at all the evidence and look at the labs and the cells in that person and whatever other tests they did and history they took, that independent committee has come back and they said, you know what, we do not have sufficient evidence to link the transverse myelitis to this vaccine, or we feel, looking at the evidence, that it is likely not caused by the vaccine. So that was their conclusion. So based on that conclusion, vaccination trial phase 3 has resumed, except in the US. So Britain, it has resumed. Brazil, it has resumed. South Africa, it has resumed, but not yet in the US. And just remember that for completion's sake, we've talked about this before. This vaccine is actually from the Oxford. It is a chimpanzee adenovirus, modified adenovirus of a chimpanzee, in which the RNA, spike protein RNA for COVID-19 has been injected, and that is what it is supposed to do in our body, come in to our body and create the spike proteins. Our immune system becomes trained, and then when the actual virus arrives, we respond strongly to it and kill it as soon as it appears in our system. It was paused on 6th September, and now it has been resumed. So if you see here, this is the AstraZeneca. So this is the news here. This is the phase 3 trial in the US, 30,000 participants. And then that's about it. So that's about the AstraZeneca, that the trial has started. Now moving on to the last topic for today. And for tomorrow, we'll have Dr. Nadir Purasan once again from Cyto9 with us. And we will talk, I wanted to understand about the mild to moderate and what is his take and what is his company's take on the results. There was some excitement and there was not some excitement, so I wanted to understand more. Plus, there were a couple of more questions that Cool Beans had been asking, and so I wanted to make sure that I can ask them. So look here, this is the third part today, prognosis by neutrophil tests. So the context of this part of the discussion, or this part of the news, is the following. It is still very important to find out a way in the labs to figure out if somebody has the propensity to become severe when the COVID-19 infects them. And I think about 4 months ago, I had done a talk in which I spoke about a need for a test where we could figure out how would our immune system cells react to COVID-19 outside of our body. And then based on that test, we could figure out who are the folks who we should protect more than the other. And this is similarly just like allergy tests. So we can do allergy tests and figure out who are the ones who are more prone or are allergic to various substances. And then we ask them to avoid those and take the anti-allergies. Similarly, it would be interesting to figure out what are the genetic profiles, what are the cellular profiles for those who become severe with COVID-19. If we can find that out, we can probably test them and kind of take care of them more often and more aggressively than others. So this is, and there are so many studies nowadays that are coming up with various kind of markers present in the COVID-19 severe and critical cases. This study here, let me show you the study. It is a small study. So where is that study? Study itself, let me just open it quickly. So here is the study. In this study, the authors study is small, so they agree that it is a small study. I think 83 people or so. In this study, what they did was they looked at hospitalized patients who were severe or critically ill. They took their cellular components, they took their cells, and then they did an analysis on what kind of cells, immune cells, were more proliferated or more present in number in such patients, to kind of figure out that what is the cellular community in our body that is pushing us towards severe COVID-19. And the result is, if we can find that out, then we can test for it. So here is what they did. What they did was they took neutrophils. So remember, neutrophils are part of our innate arm. So we have macrophages and dendritic cells and NK cells and neutrophils and basophils and other granulocytes. So neutrophils are one kind of cells, immune cells, that are part of the innate arm. Their general function is to pick up the pathogens and destroy them. At the same time, they usually do not do antigen presentation, but they kind of eat up the pathogen and destroy them. This study, what they found was, researchers, that patients that have immature neutrophils, and why would they have immature neutrophils? That means patients are making a lots of immune cells because there is an active infection going on, and bone marrow is making baby cells as well, which will spend some time in our body and become mature. So when these baby cells are being formed, that is a marker that what kind of cells are we making when we are becoming severe. And if we are making the wrong kind of cells, we should stop them from being formed. So they saw that the immature or baby neutrophil, and that is CD10 negative and CD64 positive marker cells. These are the immature neutrophils. These cells with a lot of interleukin-3 receptors and LOX-1 receptor were present in abundance in 80% of the patients who were severely ill. And so their point was that if we can now start testing people for these markers, then we can tell at the point of care who may become severely ill. So they took these 38 patients, so small study. 80% of these patients, when they were all in ICU. When they looked at these patients, they had myelemia. So cells had increased, immune cells had increased. And they saw that in these patients, those immature neutrophils that had LOX-1 receptor on them, or CD123 or interleukin-3 receptor on them, these were the cells that were more abundant. And the use of LOX-1 receptor is the following. LOX-1 receptor binds with low density lipoprotein, which is oxidized. This kind of a lipoprotein is responsible to cause atherosclerosis in our blood vessels, and in turn also responsible to cause thrombosis. So they are looking at a cell that is expressing a lot of LOX-1. So they suspected that this cell is responsible to trigger thrombosis. So remember ACE2 and angiotensin 2 and angiotensin 1 to 7 theory. So that is one theory. Bradykinin is another. And it is possible all of these things work together. Here is one more part of that theory, and that is that neutrophils that are expressing LOX-1 are in greater quantity, and LOX-1, when present on the cells, causes triggering of thrombosis or coagulation. So they saw more LOX-1. They also saw more interleukin-3 receptor expression on these cells. And interleukin-3 receptor, when they are triggered, then they cause a cellular proliferation and differentiation. What does that mean? Proliferation means increased in number. So one cell becomes 2, and 2 become 4, and 4 becomes 6. So we create an army of the immune cells that are going to go and attack the infected area. And secondly, differentiation means maturity. The cells, when they are produced, they just like naive T cells, they become T helper 1 or T helper 2. So they differentiate into the kind that is what they should become. So differentiation and proliferation is increased in the presence of CD123 or interleukin-3, which will mean proliferation will mean lots of immune cells, and that can result in bad things, lots of immune cells. Differentiation means a lot of mature immune cells, which would also be a bad thing. So when these two things were more, they saw that what would happen is in such patients who had LOX-1 increased and CD123 increased, especially LOX-1, they had a lot of interleukin-6, 8, and tumor necrosis factor alpha release. Remember, we have been talking about it. I didn't draw it because in almost every lecture we talk about it. Macrophage releases interleukin-1 and 6 and 8 and TNF and GM-CSF and many interleukin-12 and many more things. So when these cells are present, then interleukin-1, 6, 8, and tumor necrosis factor is abundantly present, which causes cytokine storm. And secondly, intravascular coagulation is increased. So based on these observations, it is an observational study. Based on these observations, the researchers' conclusion is that those patients who express immature neutrophils with LOX-1 and with CD123 receptors on their surface are especially present in those people who will become COVID-19 severely ill. So we can do that testing as soon as a patient comes to the hospital. That is what their conclusion was. So here is their conclusion. Point of care LOX-1 immature neutrophil enumeration. So that means counting the number of neutrophils that are expressing LOX-1 and CD123. And if that number, these cells are increased in number, then we should start intense anticoagulation. So if you are a healthcare professional, from this study, what they're saying is, if you see these kind of cells, then you start the patient on anticoagulant right away. So this is the discussion for today. I hope that you are keeping safe and sound. Just an update on the Cool Bean, who had the symptoms of COVID-19, and she had sent her RT-PCR as well. Her RT-PCR is negative, and her symptoms within 3-4 days have also improved a lot. So thank you for everyone for your prayers, and good to hear that she is doing better. So this is what we have today. We'll continue tomorrow with Dr. Purasan, and then we'll continue with the other topics for the week. And thank you very much for joining. Stay safe and healthy, and please like, subscribe, and share. Thank you very much.